I'm Dr. Silva, and tonight I'm going to talk to you guys about the tricyclic agents, the tricyclic antidepressants. Amitriptyline, Protriptyline, Nortriptyline, Imipramine, Desipramine, Doxepin, Amoxapine, and Clomipramine. I'm going to talk about them as a group because they share so much in common. They're all SNRIs, they're all serotonin-norepinephrine reuptake inhibitors, and they all share the same core set of side effects. So they're very similar to each other, and it's very useful just to kind of talk about tricyclics as a class before delving into the individual members just a little bit, what sets each one apart from the rest. But they are all SNRIs, and they're all potentially lethal in overdose as well, which is one thing to remember about the tricyclics. The tricyclic agents are so-called because of their ring structure, their chemical structure, and some are more serotonergic than others. Desipramine and Nortriptyline are primarily noradrenergic, and that's to say they primarily inhibit the reuptake of norepinephrine, much more so than serotonin. It's negligible. So negligible that you can safely combine those agents with MAOIs, monoamine oxidase inhibitors, and if you're an expert and you're careful about it, you won't induce serotonin syndrome. Whereas Clomipramine and Imipramine are much more serotonergic, especially Clomipramine. In the frontal cortex, dopamine is also primarily cleared away from the synapse by the norepinephrine transporter. So blocking that transporter, that norepinephrine reuptake pump, also increases concentrations of dopamine and therefore dopaminergic neurotransmission in that frontal cortex. Venlafaxine, Effexor, an SNRI, it was a big deal when it first came out around 1994. And I remember, I'll never forget, my preceptor was so excited about it because we had the SSRIs, we'd had Prozac and Zoloft and Paxil. And so here was an SNRI. And so it added norepinephrine reuptake to the serotonin reuptake. And she was very excited about it. But really, we'd had SNRIs for decades, the tricyclics. So the difference is, though, that with venlafaxine, Effexor, and then later duloxetine Cymbalta, the more modern SNRIs, they were safer and they were better tolerated because they didn't hit so many receptors. One thing about the tricyclics, and one reason why they have so many more side effects, is that they hit so many more receptors. They block acetylcholine receptors, muscarinic acetylcholine receptors, and so they have that set of side effects. A lot of them are antihistamines, and et cetera, et cetera. So what are the tricyclics used for? Well, they're no longer considered first-line agents for the treatment of depression because of their safety profile, because they have so many more side effects, and because they're lethal in overdose. So we don't reach for them as first-line agents. We have so many SSRIs and SNRIs, modern medications, multimodal medications. Even mirtazapine, which is a tetracyclic antidepressant, is better tolerated and better used than these older agents that hit so many receptors. But they were initially approved by the FDA for various forms of endogenous depression. We also use them today off-label for a myriad of conditions, especially chronic pain conditions, including fibromyalgia and neuropathic pain, especially nerve pain that may be associated with multiple sclerosis, for example, or diabetes, as well as headaches, including migraines. That's a huge indication for the tricyclic agents. They're also good hypnotic agents. They're really good sedative hypnotics, non-habit forming sedative hypnotics, because they make people very sleepy. There's no tolerance dependence or withdrawal in that sense. And so they're often added in much lower doses than what we would use to treat depression to facilitate sleep, to treat insomnia. And in fact, one of them, Doxepin, has the FDA indication for insomnia at these low doses. We're talking 10 milligrams as opposed to 50 or 150. So the antidepressant doses are much higher. So it's useful often if we have a patient with depression who's on a modern agent who maybe isn't sleeping but also not getting the full antidepressant effect that we would want it's very useful to add low-dose amitriptyline, say for example, at bedtime, and that also has the added benefit of potentially boosting the mood. We also use tricyclic agents for treatment-resistant depression, and there is evidence to suggest that the tricyclics, with all of their side effects, might be more effective at treating especially certain recalcitrant forms of depression than the newer agents. There may be a gender effect there. Men may do a little bit better with tricyclics. There's some research that shows that maybe women might actually do better on SSRIs. It's a case-by-case basis. I would not even use gender as a guideline. I would say that there's lots and lots of research that shows that the tricyclics may be better. We don't reach for it as first line, and so a lot of times we end up using it in treatment-resistant depression because we've already tried the newer agents and we're specifically looking for other things to combine with or to turn to. So that may be another reason why it's used off-label for treatment-resistant depression. Side effects. Well, first of all, the nonspecifics. Nausea. Any medication can cause nausea. Headache, diarrhea, dizziness, fatigue. Those are very nonspecific side effects. A big one, though, for these agents, as I've just described, is sedation. And we think this is mediated by these medications' antihistaminergic effects. So they're essentially antihistamines, especially Doxepin. And so they block the H1 type of histamine receptor, the type that's involved in seasonal allergies, not the type that's involved in your stomach acid. We're talking about blocking the H1 receptors. They are found in the central nervous system, and they result in sedation, which can be very significant. Mirtazapine is a tetracyclic, a little bit more modern antidepressant that's used a lot, and it too creates sedation through its antihistamine effect. So you want to dose these medications at bedtime. You want to try to use them as sleep agents as well as antidepressants. And if you do have to dose them throughout the day, you want the larger dose to be at bedtime. Weight gain is another real problem with these agents. They increase the appetite. They don't change the metabolism. They increase the appetite, especially for carbohydrates. For some reason, you're not going to crave broccoli, but the pastas and the sugary sweet foods, you're really going to want those more, and you're going to gain weight from that, and it could cause metabolic syndrome. Type 2 diabetes, hypercholesterolemia, elevated cholesterol, as well as a bad ratio of the quote-unquote good cholesterol to the bad cholesterol, dyslipidemia. You really do have to weigh patients at baseline and monitor them very carefully. That's a huge drawback and a deal breaker for a lot of patients. They also, all of them, to some extent or another, block muscarinic acetylcholine receptors. So they're anticholinergic, and you get all of the side effects that go with that, from dry mouth to constipation to urinary retention to blurred vision. Blurred vision because it impairs accommodation. So you get blurred near vision. The eyes, the pupils can't accommodate. All of these medications can cause sexual dysfunction, mostly anorgasmia and a lowered libido because of the serotonergic actions, but you can also get erectile dysfunction. That could be a consequence of a low libido, but it could also be a direct effect of norepinephrine, which inhibits the parasympathetic nervous system and it interferes with the erection. In a lot of men, particularly men that are middle-aged, they might have other risk factors like cardiovascular disease, chronic hypertension, etc. Orthostasis, orthostatic hypotension, is a loss of blood pressure, a drop in blood pressure in the cranium upon standing. Ortho means upright, erect, stasis, to stand. And so when you get up, especially if you've been lying down or even sitting down, and you come to a standing position, the blood pools due to gravity, and your vasculature is supposed to compensate by constricting to maintain pressure, but you get interference with that system with these medications, and that can lead to dizziness and even fainting and falling. we do see severe hypotension in overdose. You want to get a baseline EKG in your patients that are older than 50 because these agents can also cause QTc prolongation. QTc stands for the corrected QT interval, and that refers to the electrocardiogram, the QRST complex, which measures in milliseconds the length of a heartbeat. So in patients who already have varying degrees of heart block, you want to avoid using tricyclic agents, or in patients that already have arrhythmias, that because prolongation of the QTc could lead to fatal arrhythmia, a torsade de pointes, which looks like this and looks like this. Again, these medications are fatal in overdose. You see seizures, arrhythmias, fatal arrhythmias, coma, and death. Definitely not a good choice for patients that are chronically suicidal or the patients who are prone to overdose. Amitriptyline is considered the prototype, and it's the one that people reach for the most when it comes to treating chronic pain or preventing migraines. Migraine sufferers have reported some relief using amitriptyline, but any of these agents can help. And so as I talk about the special niches that have been carved out for some of these medications, keep in mind that because they're all SNRIs, because they're all anticholinergic to a certain extent, some more than others, these distinctions are a bit artificial. We don't have FDA indications for most of these special uses. Nortriptyline is, again, an SNRI TCA, a serotonin-norepinephrine reuptake inhibitor, tricyclic antidepressant, just like amitriptyline. But like desipramine, it is predominantly noradrenergic, so it way more blocks the norepinephrine transporter and that reuptake pump than serotonin. And so those two are the safest to use with MAOIs, monoamine oxidase inhibitors, in order to avoid serotonin syndrome. You still have to be careful, and you still have to be careful to avoid hypertensive crisis as well, mixing those. It is FDA approved for the treatment of major depressive disorder, but it's also used off-label as a second-line agent for smoking cessation and cocaine addiction because of the blockade of norepinephrine reuptake. Just like bupropion, which blocks both norepinephrine and dopamine, and it was actually approved by the FDA under the trade name Zyban for smoking cessation. You know, we don't have any magic pills for nicotine addiction or cocaine addiction, but these medications have been used. It is one of the few tricyclics where serum drug levels have been well studied. And so serum level monitoring is actually recommended. There appears to be a therapeutic window. If you don't give enough medication to achieve at least 50 nanograms per deciliter, then you're probably not going to get efficacy. But also, if you give so much medication that you get blood levels of greater than 150 nanograms per deciliter, you might also begin to lose efficacy, or those patients don't do as well. And so there's a pretty well-established therapeutic window for nortriptyline, which was called Pamelor in the United States, 50 to 150 nanograms per deciliter. And you would start to see toxicity at 500 nanograms and plus. Imipramine, an SNRI TCA like the rest, but it has more serotonergic activity than the others, not as much as Clomipramine, however. It is FDA approved for depression, but also FDA approved for nocturnal enuresis, bedwetting, in children ages 6 and older. And that's believed to be due to its anticholinergic effect, the same effect that causes urinary retention in the elderly, or just in anybody, but especially the elderly and for older people. Tightening the bladder seems to help wetting the bed at night. Although it's FDA approved, it should be noted that the World Health Organization has come out against the use of tricyclics for enuresis because of all the side effects and the potential toxicity in overdose. Desipramine, like nortriptyline, largely noradrenergic. It's more of an NRI than an SNRI. The serotonergic reuptake is negligible. It is the active metabolite of imipramine, which has more serotonergic reuptake inhibition itself. It's FDA approved for depression, and we also have plasma level monitoring available. So for non-responders, everybody's different, so that range doesn't tell us what the best dose is for everyone. Protriptyline is unique because, first of all, it has a very low dosing range, 15 to 40 milligrams a day, as opposed to up to 300 with most of the others. And you have to dose it 3 to 4 times a day. It's probably why I never used it, and also because it was a little bit before my time. But it is not as sedating, which is good because you have to dose it throughout the day. That has to do with its half-life. And it's actually more likely to be activating than the other agents. It can actually aggravate anxiety. So you might want to, you think about it, if you're going to use a tricyclic agent for those patients that are withdrawn, anergic, and not the ones that are agitated. It may also be more strongly anticholinergic than some of the other ones, and it has been noted anecdotally that it may have an earlier onset of action. It may be a little bit faster than the others for some unknown reason. Doxepin is an SNRI TCA, but it's also considered an antihistamine, straight up antihistamine, because at low doses, around 10 milligrams or so, it is a selective and potent blocker of H1 receptors, histamine type 1 receptors. And it's selective at these doses, so there's no significant anticholinergic side effects at those doses. It doesn't cause weight gain at those very low doses. It doesn't block muscarinic acetylcholine receptors to any significant extent at those lower doses. It takes much higher doses, higher concentrations in the bloodstream for it to block those receptors, because it's just not a very potent blocker of those receptors. And so you avoid the dry mouth and the constipation, the blurred vision, etc. on the lower doses when you use it specifically for sleep. And the FDA actually approved Doxepin at very low dose for insomnia. Not initial insomnia, not trouble falling asleep, but for the maintenance of sleep. So for middle insomnia, for waking up in the middle of the night. But Doxepin and really all of the tricyclic agents are useful at helping people get to sleep. At higher doses, Doxepin has the FDA approval for various depressive variants. Doxepin is the only tricyclic that's available in a topical preparation, because if you smear it on your skin, you'll actually get good systemic absorption. It gets into your bloodstream, and it's often used to treat pruritus, itching. Where psychiatry and dermatology intersect, the neurodermatitis syndromes, you would especially think about Doxepin. And so this would be chronic itching without any identifiable cause, spontaneous idiopathic itching, which is thought to be a psychosomatic illness. Psychosomatic meaning that it's tied to stress and worry and anxiety, tied to emotion, not that the patients are imagining their symptoms. And so if stress can give you ulcers and cause migraines, and it can make you also break out in a rash, it can make you have itching that's prolonged. A patient might get a rash and then they are itching and then they never stop itching. And so they can take antihistamines for that, but Doxepin might be the best antihistamine because it also happens to be a tricyclic antidepressant. By the way, dermatology and psychiatry also intersect with delusional parasitosis. So that's a sidebar. You can look that one up. That'd be a good video. Amoxapine, which is sometimes considered a tetracyclic antidepressant. It is a metabolite of loxapine, which is an antipsychotic agent, and both amoxapine and its active metabolite block dopamine 2 receptors, just like Haldol and Risperdal, antipsychotic agents of the first generation, as well as blocking the serotonin 2A receptor, so they are also approximating atypical antipsychotics, the third generation of antipsychotics. And all of those actions will reduce the positive symptoms of psychosis, hallucinations, delusions, and so amoxapine is the tricyclic that we think of when we are maybe wanting to treat a depression, a major depression with psychotic features. Amoxapine would be the medication you would choose. So Amoxapine increases dopamine in the frontal cortex because it's blocking the reuptake of norepinephrine, and dopamine relies on those pumps in the frontal cortex, but then it's blocking dopamine type 2 receptors in other areas of the brain where you might be having positive psychotic symptoms. But because of the dopamine blockade, you're going to get some special side effects that you wouldn't get with the other tricyclic agents, such as akathisia, which is a motor restlessness, a fidgetiness, a need to move, being very uncomfortable being still, which can, in its severe form, looks like pacing. A person just cannot sit still. They just feel like they're going to crawl out of their skin if they don't move. You can also get drug-induced Parkinsonism because you are blocking those receptors in the motor areas of the brain, the nigrostriatal pathways, just like in Parkinson's disease when cells in those pathways just naturally start to degenerate, so you can get the rigidity and the tremors and all the other things that come with blocking dopamine. And tardive dyskinesia, theoretically, if you gave enough milligrams for a long enough period of time, in some patients, they would develop this condition that consists of abnormal movements that can be permanent. And so you do have to weigh that into consideration if you're going to be treating chronically. And then finally, Clomipramine, which is the most serotonergic of the tricyclic agents, and that's why it's my favorite. I did a whole video on that, so I encourage you to check that out. It is still first-line treatment for OCD, which can be a stubborn one, and certainly any depression that's agitated and has a lot of anxiety. If you're going to use a TCA, think Clomipramine. So that's it. Those are the tricyclic agents in a nutshell. Thanks for listening. Comments are always welcome.